We will now proceed to the second tutorial case. This is a cerebellopontine angle tumor. As usual, we'll start off with the tutorial cases knowing the diagnosis beforehand. The history is a 65-year-old retired man had a chief complaint of dizziness that had been worsening over the past 6 months. The patient's major symptom was disequilibrium without vertigo, which was present daily, occurred with head movement, and was particularly bothersome when walking. He noted veering of his gait both to the right and to the left. There was also a complaint of hearing loss and tinnitus in the left ear that was worsening gradually. He had no significant medical history and the family history was non-contributory. So the question is, based on the patient's history, what diagnosis should be considered? So is it possible that we can actually make an anatomical localization of the problem based on the patient's history itself? And can we have some kind of a conclusion at this particular stage based on what history has been provided? The important points in the history, just to reiterate again, is of course there is a complaint of dizziness that has been progressing or worsening over the past 6 months. So this is not an episodic condition, this is clearly a chronic condition. And this chronic condition has also been progressing. It is not a condition that is the same, it has been progressing. So 2 points, it is not episodic, it is chronic. Second point, it has been progressing. The next thing is there has never been a spinning vertigo, which was present, but the disequilibrium is present almost daily. Occurred with head movement. Whenever he made a head movement, the disequilibrium was worser. It is not like a spinning vertigo which was brought about by a position change or anything. Whenever there was a head movement, it was the disequilibrium worsened. And this particular problem of disequilibrium was particularly bothersome when walking. This is not a patient who is complaining of a problem while lying down. This is not a patient who is complaining of a problem while sitting in one place, not even just standing, but it is actually a problem of walking. And especially more detailed, the exact problem in his walking is that he was veering to the right and veering to the left, both sides. There is no directionality, he is veering to both sides, to the right and to the left. In addition to this, there has been a complaint of hearing loss and tinnitus in the left ear that was worsening gradually. Now we need to try to put these two things together, the symptoms related to the ear and then the walking related difficulty, which cannot, this kind of a progressive condition which is not that easy to explain by a pure otological condition. So there are two things that are happening. So there is an otological condition, clearly tinnitus and hearing loss is otological, and there is something else which is non-otological. So these two things coming together is what is the anatomical localization which leads to. So based on the patient's history, what diagnosis should be considered? The patient's history is consistent with both vestibular and auditory abnormalities. Moreover, the disequilibrium without vertigo and the gradually worsening course suggest the possibility of a central vestibular abnormality. Diagnostic considerations that can account for the patient's hearing loss, tinnitus and imbalance, okay, when all the three things are together, include a CP angle mass, or very unlikely a peripheral otological condition, but it is less likely. The differential diagnosis, if for the patient of balanced symptoms, if there was no hearing loss and no tinnitus, then it is a huge differential diagnosis. But here, if there is a common explanation for the auditory symptoms and for the symptoms of patient's disequilibrium, especially the imbalance while walking with veering to the right, veering to the left. These specific words when somebody uses veering to the right and veering to the left, when that and this both of them are happening, then it leads to CP angle mass. The physical examination. Neurologic examination indicated a Bruns nystagmus. What is a Bruns nystagmus? A coarse gaze-evoked nystagmus during leftward horizontal gaze. When the person was asked to look to the left, there has been a coarse nystagmus. It's a large amplitude nystagmus. and a fine vestibular or horizontal torsional nystagmus on the rightward gaze. So on right gaze there is a fine nystagmus, on left gaze there is a large amplitude coarse nystagmus. This combination, on one gaze there is a coarse and large amplitude nystagmus, on the other side there is a very fine nystagmus. This combination together has been given a term called Brunn's nystagmus. There was no spontaneous nystagmus with eyes open in room light. With infrared goggles, the patient was noted to have a primary position right beating horizontal torsional nystagmus of small amplitude. There was no alteration of strength or sensation or incoordination of the limbs. The patient had an ataxic gait. So there is no incoordination of the limbs. So there is no appendicular incoordination, but there is ataxic gait, means the gait itself there has been a problem. Romberg's test was negative, but he could not stand on a compliant foam pad with eyes closed. With eyes closed, the person is not able to stand with eyes closed on a compliant pad on foam. Bedside evaluation of the patient's hearing indicated that Weber's test lateralized to the right and the Rinne test was positive bilaterally, indicating a sensorineural hearing loss on the left. So Weber test was lateralizing to the right, which means the right ear is the better ear. Rinne was positive, which means ear conduction is better than bone conduction. There is no conductive component. So finally, this leads to a sensorineural hearing loss on the left side. Now, just let us see a few examples of this Brunn's nystagmus before we actually proceed to dissecting this Brunn's nystagmus and trying to understand what exactly leads to the Brunn's nystagmus. So this is from the JAMA network. This is a video supplement to a paper submitted by Venkateshwaran, Gupta, Swaminathan, Brunn's nystagmus in CP angle tumor. So I am just playing that from YouTube. So Brunn's nystagmus and contrast enhanced computed tomography of the brain. Gaze to the right reveals large amplitude, low frequency coarse nystagmus. Gaze to the left reveals low fine nystagmus. So you can see on the right gaze, you can see a coarse nystagmus. On the left gaze, there is a very fine nystagmus, very fine nystagmus. You can look up this video on YouTube and then get a better quality video. You can see on the right, there is a very coarse nystagmus, If you see more detail, the eyes tend to come all the way up to the midline. They tend to come all the way up to the midline when they are trying to hold their gaze to the right side. But when he is looking to the left, that is not the case. So these are some examples that have been provided there as a video supplement. So on the right, you see this coarse nystagmus. This coarse nystagmus is actually, if you can describe it in another way, a tendency of the eyes to come to the midline. Tendency of the eyes to come into the primary gaze. Okay, see, it is almost coming. And if the person makes an attempt again to go to this, so that is what is leading to the nystagmus. The person is making an attempt to look to the right and therefore it is coming to the right. Otherwise, it is just slowly drifting all the way up to the center gaze. Okay, drifting all the. So this is what is happening in the course. So these are few examples. So right side in this particular example was coarse nystagmus. On left gaze there was a fine nystagmus. So we will proceed with the discussion further now. So now, after the physical examination, what is the mechanism of this patient's nystagmus? The first question that we are trying to answer is, what is the mechanism of this particular patient's nystagmus? Brunn's nystagmus is a combination of a gaze-evoked nystagmus in one direction and a vestibular nystagmus that beats in the opposite direction. Opposite means the direction opposite to the side of involvement. So the gaze-evoked nystagmus is based on a cerebellar lesion ipsilateral to the direction of gaze-evoked nystagmus. So the cerebellar lesion, if it is on the right side, there is going to be a gaze-evoked nystagmus on the right. If the cerebellar lesion is on the left, there is going to be a gaze-evoked nystagmus on the left gaze. The vestibular nystagmus is based on a vestibular lesion contralateral to the direction of the vestibular nystagmus. So in this patient's case, the gaze-evoked nystagmus is left beating on left gaze and suggests a left-sided cerebellar lesion. In the examples that we saw from YouTube of the JAMA network, it was the opposite. There was a gaze evoked nystagmus on right gaze and there was a vestibular nystagmus on left gaze. Whereas in the patient that has been given to us, the gaze evoked nystagmus is left beating on left gaze and suggested left-sided cerebellar lesion. The vestibular nystagmus is right beating on right gaze and suggests a left-sided vestibular lesion. So right beating nystagmus, vestibular nystagmus. In the first tutorial case, we saw what exactly is a vestibular nystagmus. A vestibular nystagmus is a horizontal torsional nystagmus which can be suppressed with fixation, which simply means if this same patient was examined on removal of fixation, then the nystagmus, the vestibular nystagmus or the nystagmus that you are seeing on right beating nystagmus on a right gaze should become more. So the way it can become more is when the person looks to the right, it can be more frequency, okay, or more intensity, or it can so happen that even in the primary gaze, the right beating nystagmus will start showing up if the fixation was removed. So then is when it will be called as a vestibular nystagmus. So this particular patient has a vestibular nystagmus. So right beating vestibular nystagmus simply means the left side ear is deficient. So this is what we saw in the first case also. The first case where we discussed about vestibular neuritis. If there was a vestibular neuritis on the right, there is going to be left beating nystagmus. If there is a left-sided vestibular neuritis, there is going to be a right beating nystagmus. So simply here, the vestibular nystagmus is right beating on right gaze simply means that the right side is intact and there is a left side vestibular weakness. So the vestibular nystagmus which is right beating suggests that there is a left-sided vestibular lesion. And the gaze nystagmus or the gaze evoked nystagmus, the large amplitude nystagmus which you saw on the left side also means that there is a cerebellar lesion on the left side. Thus, this patient is likely to have a left-sided vestibular lesion and a left-sided cerebellar lesion. Both together is what we are discussing here. So, the right beating vestibular nystagmus that can be observed in the primary position with infrared goggles can often be seen only in the right lateral gaze rather than in the primary position when the patient is examined in light. So this is how the nystagmus grade increases or the nystagmus becomes more pronounced on removal of the fixation, the vestibular nystagmus. Now, a little bit detail of what exactly is happening on the gaze evoked nystagmus. Why is there a gaze evoked nystagmus? To note here is all these patients that you saw from the JAMA network, they were actually getting this nystagmus, the gaze evoked nystagmus with fixation. So, what is the essential thing for somebody not to get a nystagmus on moving the eyes to one eccentric position? There are two things that will keep the eye from drifting to the center once the eye has moved to one eccentricity. So, you ask the person to look to right or you ask the person to look to left. When the person actually looks to that one particular direction, there are two things that can happen that can keep the eye in that particular position. The first thing is what we call as a neural integrator mechanism. The neural integrator mechanism is, this is something that happens in real-time online processing. So what is that in real-time online processing that happens is, when the eye starts moving to the left, the command that takes the number of action potentials that are generated to take the eye to that one particular side, to the right or to the left, whichever side the eye is moving, a copy of that particular neural command goes to the neural integrator, which tells, okay, this eye has been moved for so long at this velocity, therefore this eye would have reached this particular position. It is like somebody gives a vehicle speed and somebody tells this particular vehicle went at this particular speed for this amount of time, where would have reached. It is very easy calculation. So in the neural integrator, what exactly is happening, the gaze holding neural integrator, what exactly is happening here is, when the saccade is generated to take the eye to one particular direction, inline processing tells that, okay, this particular eye was moved at a certain velocity, say 200 degrees per second for this amount of time. Therefore, this eye would have moved by, say, 200 degrees per second for a quarter second, something like that. So it would have moved by 50 degrees. So something like that, we know the calculation of the eye position is done inline. So even There is no need for a proprioceptive mechanism, there is no need for any other mechanism to tell where the eye would have reached. Where the eye would have reached has been calculated based on the neural signal that is actually taking the eye there. The signal told, I am moving the eye at this velocity for this amount of time, therefore it would have reached here. Based on that signal, that this amount of time this was fired for this, at this velocity, the eye would have reached here. So if the eye has reached this position, I need to generate this amount of force in the extraocular muscles to hold the eye there. Why should the eye be held there? Because the elastic recoil forces of the eye will try to pull the eye back into the center. Therefore, a force has to be generated to keep the eye in the eccentric position. How much force is generated, how much force is required depends on how eccentric the eye is. Because this is like an elastic recoil. The more you pull the spring, the more you need strength to hold it elongated or hold it pulled. A spring is just little pulled, you need less energy to hold it. A spring is held pulled longer, you need more force to hold it. So the eye being pulled from center position to the eccentric and eccentric, more and more eccentric, more and more force is required. So this is what is going to, this is one way in which the eye's eccentric position can be maintained. So this is inline processing. That happens when the saccade is generated. The next thing that can keep the eye in that particular position is, even if there is no inline processing, okay, maybe for a moment that will fail, but afterwards the eye can still be held there by generating another kind of force, another kind of drive that moves the extraocular muscles. That drive is actually the fixation mechanism, right? So the fixation mechanism drive also can keep the eye in that eccentric position. This fixation mechanism is nothing but a mechanism to hold the eye steady on one particular object. That particular object, if it is stable in one place, you call it fixation. If that particular object is moving, we call it smooth pursuit. That's all. Neuroanatomically, the smooth pursuit and the fixation mechanisms are almost same. So if the fixation failure is there, smooth pursuit failure is also there. So in this particular person, we are seeing that there is a failure of both. There is a failure of inline processing and there is a failure of processing or fixation or smooth pursuit in that particular side. So this is a gaze paretic nystagmus. What does it mean, gaze paretic nystagmus? This person is not able to hold the gaze in an eccentric position. That is why when you saw so many videos from the JAMA Networks collection, almost every patient showed one behavior of the eyes almost drifting almost up to the center or primary gaze, up to that. Till then, okay, and then the patient makes another attempt to take the eye to one side. Saccades themselves are able to take the eyes to the eccentric position, but the eyes cannot be maintained in the eccentric position. So this is happening even with fixation. Even with fixation it is happening, because even the fixation mechanism or the smooth pursuit mechanism has failed, which means at this stage itself we can expect that this person's central ocular motor findings will show some problem with the smooth pursuit too. So let us proceed to what exactly happens then. So based on the patient's history and physical examination, what is the most likely abnormality and what diagnostic tests should be performed? So the patient is likely to have a left cerebellopontine angle neoplasm. Diagnostic considerations include a large acoustic neuroma or a meningioma. Okay. An aneurysm acting as a mass lesion. One of a number of uncommon posterior fossa neoplasms such as an epidermoid tumor, chordoma, lipoma, or rarely even a metastatic tumor. The patient should undergo MRI of the brain with special attention to the CP angle. Auditory and vestibular testing would also be helpful to delineate the patient's functional abnormalities, to what extent the functional abnormalities exist. But the diagnostic test here is going to be an imaging study. So what did the investigations reveal in this particular patient? We were expecting some abnormalities in the investigation. Let us see that. The video nystagmography. Ocular motor testing revealed overshoot saccades to the left. So, saccades in one direction were overshooting. These are called saccadic pulsions. An asymmetric impairment of ocular pursuit with difficulty pursuing targets moving to the left and a normal optokinetic nystagmus. So what exactly was happening is the person is not able to pursue targets moving to the left. Towards the left when the target is moving. So if the target moves from left to right, the person is able to easily follow that without any saccadic, nicely, smoothly follow that. But when the person is tracking to the left, there is this is called there is a saccadic pursuit. The pursuit failure is there. So as we saw before, this particular patient also has a gaze peritic nystagmus. The person is not able to generate the particular fixation mechanism or smooth pursuit mechanism in that direction. That is why the person had that kind of a nystagmus in the first place. Two things need to fail for the person to have a nystagmus even with fixation. One is the saccade, during the saccade inline neural integration has failed. After that, the fixation mechanism or the smooth pursuit mechanism has also failed. And that is exactly what we are seeing here. A right beating spontaneous vestibular nystagmus was seen in the dark, which again means that there is a left side problem. So this also tells to generate leftward pursuit, left-sided cerebellum is required. Okay. So because in this particular patient, impairment of smooth pursuit with difficulty pursuing targets moving to the left. So if the eyes have to be moved in the leftward direction, from right to left, the left-sided cerebellum is what is required. Caloric testing revealed a reduced vestibular response of moderate degree on the left side. So which again means that there is a left vestibular deficit. Rotational testing revealed asymmetric responses with more right beating nystagmus than left beating nystagmus. So what is the meaning? The right side is intact. Right ear, for rightward rotations, right ear at higher velocities, the right ear generates the right beating nystagmus. For left-sided rotations, the left ear generates the left beating nystagmus at higher velocity. At lower velocities, any ear can produce any nystagmus. So at higher velocities, there is. So you see in rotational, there is an asymmetry. One side rotations is producing very good nystagmus, that is the right side or the intact side. On the left side, there are less nystagmus. The vestibular evoked myogenic potentials were absent on the left. Again, this pathway is also affected because there is a tumor involving the vestibular nerve. Posturography testing indicated excessive sway on conditions 5 and 6. That is a vestibular pattern. Vestibular pattern means there is a particular condition in which the vision is not reliable or vision is not available to the patient. This is a particular test in posturography where the eyes are closed or eyes are looking at something where it is not reliable. The vision cannot be relied upon for postural balance. The person is looking at something which is moving with the person's sway, which means it is no longer reliable. So when that kind of a condition is given to this particular patient, the person shows excessive sway. This is what we do in the clinical test. In the clinical test, when we actually make the person make the person stand on the foam and then close the eyes, this is similar to that particular condition. Audiometric testing revealed a moderate to severe sensorineural hearing loss on the left with a word recognition score of 30%, which is a very poor speech discrimination. Hearing was normal on the right side. An MRI scan of the brain revealed a 4 cm mass in the left cerebellopontine angle that filled the porus of the left internal auditory canal. There was a shift of the cerebellum and brainstem caused by a mass effect of the tumor. So this is the image of the tumor, okay, which is in the CP angle and is also having a mass effect, okay, on the cerebellum and also in the middle cerebellar peduncle region. What additional information was provided by the laboratory testing, which we did not know with clinical history and with physical examination? The MRI scan confirms the clinical suspicion of a CP angle tumor. This scan is most suggestive of an acoustic neuroma. Audiometric testing suggests that the patient has little functional hearing remaining in the left ear. Vestibular testing confirms the presence of both peripheral and central nervous system abnormalities. The smooth pursuit abnormality, the saccadic overshoots that we saw. The patient's caloric and VEMP reduction suggests impairment of afferent vestibular activity on the left. The abnormal saccades and pursuit suggest impairment of cerebellar or brainstem function. The patient's spontaneous nystagmus and directional preponderance on rotational testing indicate an ongoing vestibulocular asymmetry. The posturography suggests that some of the patient's imbalance is a result of vestibular dysfunction. Okay, some of it is definitely because of vestibular imbalance, is because of vestibular dysfunction, because the patient did bad or more worse when in the vestibular protocol. In the vestibular protocol where the eyes were closed and the surface on which the person was standing was not reliable, or eyes were not reliable and the surface was not reliable. The diagnosis and differential diagnosis, the patient's history, physical examination, laboratory studies indicate a CP angle lesion with a mixed central and peripheral vestibular disorder. Now, in what way do combined peripheral and central vestibular abnormalities interact to cause a synergistic adverse effect on patient's balance? This is where we need to compare and contrast this particular patient with the first tutorial case that we saw. As noted in case 1, patients with a normal central nervous system can compensate for a peripheral vestibular lesion and become nearly symptom-free. In fact, this is also what happens in the early stages of a vestibular schwannoma, before the cerebellum gets involved. They really do not have many balance symptoms. They even do not have vertigo. And it is slow growing. It is only when they start again, it starts compressing the cerebellum, is when they start showing the balance or the postural symptoms. Vestibular compensation requires changes in vestibular processing, the brainstem and cerebellum, particularly the vestibulocerebellum. This patient's CP angle lesion has caused a left-right vestibular asymmetry, and as evidenced by the patient's neurologic signs, has impaired the function of some of the central nervous system structures important for vestibular compensation, brainstem and cerebellum. Thus, despite a vestibular loss that is gradual rather than acute and partial rather than complete, the patient has symptoms of dizziness and imbalance, suggesting that vestibular compensation has not been successful in this particular patient, or even if it had already happened, that has become decompensated again when the cerebellum and the brainstem started getting involved by compression. So what are the causes of combined peripheral and central vestibular dysfunction? What are all the things that should come to our mind whenever we see a combination of peripheral and central vestibular dysfunction? The causes of combined peripheral and central vestibular lesions include large CP angle lesions, as in this case. We are going to see further cases like ICA infarct, a traumatic case, and a multi-system degeneration case in the further discussions, as in Friedreich ataxia. Also, some patients with peripheral vestibular lesions have pre-existing central nervous system abnormalities that prevent normal compensation from occurring. So, if the person is already have some central nervous system abnormalities, and on top of it the person develops even a vestibular neuritis, that individual will not compensate well. The patient was treated surgically using a translabyrinthine approach. The diagnosis of an acoustic neuroma was confirmed on pathologic analysis. Complete tumor resection was accomplished with preservation of all cranial nerves except the 8th nerve, which was the involved nerve, which was resected with the tumor. Post-operatively, the patient has had no complications and was referred for vestibular rehabilitation therapy. The follow-up, the patient recovered uneventfully from the surgery. 3 months after surgery, he reported tiring easily and continued to have mild to moderate unsteadiness and disequilibrium. He was reassured and encouraged to keep up with his home vestibular rehabilitation program and to avoid vestibular suppressant medications. The summary, a 65-year-old man presented with a gradual onset imbalance, gradually progressing imbalance, and unilateral tinnitus and hearing loss over 6 months. Physical examination suggested a mixed central and peripheral vestibular lesion. MRI scanning confirmed the presence of a CP angle tumor. There are certain patterns that we need to see in clinical practice where we need to immediately think in terms of a CP angle tumor, especially when it is so big. Auditory symptoms and veering while walking. If the patient has a veering while walking and it's been going on for few months and also has auditory symptoms like hearing loss, then we should just ask for an MRI. MRI scanning confirms the presence of a CP angle tumor. The veering is that important word. Almost all patients who come to us with a CP angle tumor pressing on the cerebellum, they do complain of this veering while walking. Vestibular studies documented both peripheral and central vestibular abnormalities and abnormalities of ocular motor control. The patient demonstrated impaired compensation for his peripheral vestibular abnormality. Treatment consisted of surgical resection of the tumor and vestibular rehabilitation. Follow-up evaluation showed mild to moderate residual unsteadiness. Now, what are the teaching points? A CP angle lesion should be suspected in the setting of dizziness associated with unilateral asymmetric hearing loss or tinnitus. In fact, at this point of time, when there is a dizziness, chronic, progressive, and hearing loss, it has to be diagnosed. We have to have a very low threshold to ask for imaging study in that particular patient. In fact, the difficulty in diagnosing patients is when the CP angle is, when this particular vestibular schwannoma or what is called as an acoustic neuroma is restricted in the internal artery canal. That is the time where there is more difficulty. Once the person actually reaches a stage of chronic disequilibrium, especially walking, veering while walking, at that stage, we should not be hesitating to do an MRI. And in fact, it is a must to do an MRI immediately when you come across a patient like that. Auditory symptoms plus postural symptoms, gait abnormalities where they are having veering. Diagnostic consideration should include a large acoustic neuroma or meningioma involving the posterior fossa. Several uncommon tumors may also affect the posterior fossa, including epidermoid tumor, chordoma, lipoma, rarely even metastatic tumor. A vertebrobasilar aneurysm acting as a mass lesion may also present with similar symptoms. The patient should undergo MRI of the brain with special attention to the CP angle. Large CP angle tumors may produce a combination of peripheral and central vestibular abnormalities. Both vestibular nerve and cerebellar function may be impaired. These impairments may be manifested by abnormal ocular motor tests, spontaneous nystagmus, a reduced vestibular response on caloric testing, a directional preponderance on rotational testing, and abnormal posturography. Most other investigations are just to measure the functional deficit. The primary investigation here is MRI. Combined peripheral and central vestibular abnormalities interact to cause a synergistic adverse effect on patient's balance. With a normal central nervous system, patients can compensate for a peripheral vestibular lesion and become nearly symptom-free. However, if central nervous system abnormalities involve the structures that are critical for vestibular compensation, that is, the vestibular nuclei and the vestibulocerebellum, a peripheral vestibular lesion may produce persistent symptoms resulting from impaired compensation. Combined peripheral and central vestibular dysfunction may be caused by large CP angle lesions, ICA, anterior inferior cerebellar artery territory infarction, trauma, multi-system degenerations. Okay, the things to keep in mind when there is a combined central and peripheral vestibular dysfunction. Also, some patients with peripheral vestibular lesions may have pre-existing central nervous abnormalities that prevent normal vestibular compensation from occurring. Bruns nystagmus represents a manifestation of a combined peripheral and central vestibular abnormality. Bruns nystagmus is a combination of gaze-evoked nystagmus in one direction, gaze-evoked nystagmus or gaze-paretic nystagmus, where the person could not maintain an eccentric gaze. We discussed why exactly the person cannot maintain an eccentric gaze here. Two things have failed. The inline processing of the position that is going to be reached, that is the neural integrator for gaze holding, has also failed. The fixation or the smooth pursuit mechanism has also failed. So, two of them led to this gaze-evoked nystagmus in one direction, presumably based on ipsilateral cerebellar lesion and a vestibular nystagmus in the opposite direction. Bruns nystagmus is highly suggestive of a CP angle tumor. So, with that, we finish the discussion of this second tutorial case. Thank you.